All right, good. Got that.
So while we're waiting, what do you think of these COVID toes?
COVID toes.
COVID toes.
I mean the Kawasaki or the vasculitis that people are saying.
Yeah, where a lot of these COVID patients are getting what looks like purpura.
Right.
Hi, Kevin Steele. Hello. Hello, Fun with Nick Line. I remember you.
All right.
Hello, Rachel. Brian.
Okay. I can't. Mike, where are you seeing all these people? Why do I always have trouble with
Do you have your comment section open? Hi, Crystal.
on Ecamm?
Yeah.
Okay. All right. Hey, Marco. All right, I got Marco here. All right, cool.
Guys, can you hear both of us? If you can't, give a two thumbs up.
Hey, Crystal. Hey, William. Hey, Kurt. Hey, Anne Rain. I've also got. If you guys have any question on Dr. Mike's channel, I've got his open, so I can answer any questions and anything to anyone on my feed. I'll ask Dr. Mike on your behalf too. So you guys don't need to be hopping around. All right, we'll
All right,
just.
someone asked me, does broad spectrum antibiotics help with COVID? Nope. So with viruses, the antibiotics don't work. There's some exceptions where, for example, sometimes in patients with COPD exacerbations, meaning emphysema, even though it's 90% viral that's causing their bronchitis, sometimes we do give azithromycin, only because azithromycin actually has some kind of anti-inflammatory effect, and that's why we give it in those instances, even though 90% of the time the bronchitis and COPD is caused by a virus and not a bacteria. So to answer your question, though, broad spectrum antibiotics aren't going to work for this coronavirus. And actually, they were looking at secondary pneumonias in patients with coronavirus, and when they were doing autopsies, they didn't see that any of these patients were having secondary bacterial pneumonias after they got the virus. So that was actually somewhat surprising finding, because lots of times when you have a bad viral infection that lands you in a hospital on a ventilator, lots of times they do get secondary bacterial infections.
Um, so I know that I got a lot of questions about Leronlimab, about cytidine. A lot of questions on that. Obviously, I did a video, so if you guys haven't seen my video yet, you can go check it out on Leronlimab. Dr. Mike did he did a really great video on clots. So if you guys want to direct a lot of your questions just so that we can streamline things to Dr. Mike, and if you guys have any questions about leronlimab, I'll talk a little bit about the carbohydrates. I know you guys are itching for the carbohydrates and the glycan talk. So maybe we'll just start out with first going over some of the. I know I have a lot of questions on endothelial damage at Kawasaki. You wanna tackle those, Mike?
Yeah, also remdesivir is a frequent one that's popping up, as well as someone was mentioning Rantes. So I'll start with remdesivir. So even though it's got the green light for COVID patients, when you look at the study, it actually wasn't very impressive. So yes, is it better than nothing? Yes, but it's definitely not the cure that we're hoping for. It's not the magic pill that we're looking for, but it does look like it's better than nothing. So we'll take that as a start, especially because it doesn't really, it's not really showing much in the way of side effects.
Guys, if you can hear me, can you give me a thumbs up? mic. I'm not sure if my audio is
When I
coming
asked
through now.
them to do 2 thumbs up, they did 2 thumbs up if they could hear us both.
No, I turned off my mic. Can you guys hear me right now? Yes. Okay.
Yep.
Thumbs up. Thumbs
Okay.
up. Okay, great. Awesome. Sorry guys. Like I say this every week. Dr. Mike and I didn't go to med school for audiovisuals, and I'm still getting. Okay, awesome guys. All right, let's rock and roll. Let's go.
So they're asking. So I answered about remdesivir. They're also asking about rantes, and I'll let you handle this one.
Okay, here's the rantes question. I guess we're going to jump into leronlimab. Okay, so leronlimab, there is the Nature study that's coming out this week. I was on the phone with Dr. Lalazari yesterday. I've been talking with everyone from Cytodine. I do not know this company. I have no connection with these guys. I have no ties with them. They don't pay me for anything. Doing my own research like Dr. Mike. Leronlimab is a monoclonal antibody, an IgG, that is, it blocks the CCR5 receptor. CCR5 is a receptor found on T cells and macrophages. And they initially did these studies on HIV. Leronlimab was, if you look at the study now or look at the papers, it's all from HIV. They had enrolled about over 800 people in a ton of clinical trials. As of last Monday, they submitted a BLA to the FDA, which is really one of the last steps to getting approval for HIV. Where we stand right now with leronlimab is they have a Monty study that's going to be in the Nature paper that's coming out this week. I've had a chance to look. It's going to be pretty mind-blowing. That's all I'm going to say. What Dr. Porhasan and what Dr. Patterson came out in their conference call last Monday, I can confirm everything that they said is in this paper. So keep an eye out for it. They looked at 10 patients at Monty. As they stated in their conference call, they have a normalization of interleukin-6 by day 14, a decrease of interleukin-6 by day 7. What Dr. Patterson found is this is not an interleukin-6 disease. This is a rantes disease, and this is going to be clearly defined in this paper that is rantes. Rantes is another a cytokine. It's a subset of cytokines called chemokines. And again, as I posted this video going over the exact mechanism. It's a whole cartoon diagram that I drew up. Now, the thing with leronlimab, one of the nice things they also found was a decrease in serum viral load or plasma viral load, which is huge because this is a drug that's really targeting the cytokine storm, but it's also having an effect of they were able to quantify the decrease in plasma viremia. And the other thing that I was surprised about was what we know about coronavirus is that it in some ways acts like HIV. And I know the conspiracy theories guys are going to talk about, oh, is it built? Is it like a lab manufactured? I'm not going to go there. There is a suppression of CD4 and CD8 count in coronavirus. This is documented. Immunosuppression taking place. And leronlimab normalizes CD4 to CD8 ratios, which is a huge groundbreaking finding. One of the things that talking to Dr. Lalazari, they're trying to get leronlimab out in the open to have clinical trials. They're running through a lot of red tape and bureaucracy with the FDA. Me personally, someone that is completely independent, I see a lot of promise with leronlimab.
Yeah, and so other people asking questions about testing. So is the antibody test accurate? Well, multiple parts to that question because there's 2 tests, right? There's the reverse transcriptase PCR test, and then there's these IgG, IgM antibody tests. And the accuracy of these tests depends on a lot of different factors. For example, with the PCR test, it depends on the company making it. Has the test been tested for both sensitivity and specificity? That's what determines the accuracy of the test. But also, how well is the test being done? For example, when you go to do a nasal swab, when a nurse does a nasal swab, they have to get all the way back in there, and that actually really hurts. That's not comfortable. So if you don't do a good job of essentially causing pain to get all the way back there, there's a good chance that they don't actually get to where they need to go, and therefore don't get an adequate test. So if they send that off without getting a good sample, then there's a good chance that's going to come back negative. We also know that the virus tends to hang out more in the nose than it does the mouth. So uh, that's why we do both places, not just one or the other. The other thing is we know that if you get samples from a bronchoscopy procedure, meaning that's a procedure where we go in the mouth, sometimes the nose, but we go down the throat and all the way down into the lungs, and then we squirt some fluid down there, and then we suck it back up. When we do that, that's actually the best way to do the test. That's going to have the highest accuracy of the test. The problem is that we don't want to do that procedure just to get a test because it is an invasive procedure, and also it's a lot of PPE and it's a lot of work to go in just to do a test. So it's not a very practical thing to do just to get a test. So to answer the question, the actual gold standard as of right now is by means of doing the PCR test through the nose, through the company. There's I think 4 companies that have very high accuracy. One of them is Cepheid. And then as far as the antibody tests, there are not a lot of FDA approved antibody tests available that have been proven to be accurate. So a lot of these are made by private companies. And I actually know a lot of people, especially I know of celebrities who are getting these private tests because someone knows someone and they have money and they're able to get these private tests from people that aren't available to the rest of the public. But that doesn't mean that those tests that they're getting are necessarily accurate. The ones that are accurate are the ones that are FDA approved and have been proven to be both sensitive and specific for COVID-19. So to answer your question, the accuracy of these antibody tests, it really depends on who's making it and has that specific test been made by a company that's been FDA approved, and what are the numbers? Specifically, what is the number of the specificity? What is the number of the sensitivity? So sensitivity means if you have a low sensitivity, that means you might miss the diagnosis. A low specificity means, well, if it comes back positive, is it specific to that disease, or is it could be something else that's causing it to be a false positive?
Mike, I just got my Leronlimab questions just blew up over here. So I'm just gonna just go
Yeah,
back since I just talked about it, so we're
sure.
not hopping around. I got a question about how easy, I guess, the scalability of this. I'm not sure what the cost of it. I mean, as any experimental drug will be, there's obviously a significant cost. But Dr. Porhasan and Dr. Lalazari have told me they are giving this drug out for free as long as any hospital can submit the paperwork through an EIND through the FDA. Right now, what they are facing is a lot of hospitals, a lot of doctors, and probably I understand from the doctor side of things, haven't been a lot of data and studies that are coming from Leronlimab. A lot of it is from the HIV studies. Here's the interesting point, and I emphasize this in my video. There are no serious adverse events in over 800 patients studied in leronlimab with HIV. None. And you guys can go into the NIH website. If you go in my video, I think I put a link to it and kind of go over that. I think the worst is some diarrhea and I think a little bit of hypertension, but nothing really significant. If you look at remdesivir, one of the major side effects, and this is an exclusion criteria for a lot of patients, is the liver enzymes, and this is the same thing for tocilizumab. I know a lot of patients personally that they were not able to get remdesivir and tocilizumab because of liver enzymes. What Dr. Patterson is saying is that rantes is the cytokine that is causing all the damage to the liver. It's rantes, rantes, rantes. So in terms of scalability, they have again, I don't know sort of the marketing side, but I do know they have a partnership with Samsung. Just remember, leronlimab's been around for several years. They're already close to getting it to be the drug of choice for HIV. It's just phenomenal results. They've got studies on cancer metastasis, which you guys should just go and check it out. Which just mind-boggling that we don't know that this drug is not talked about anything more. I'm going to point out a couple of things from what Dr. Lalazari told me. Was in their UCLA study, they looked at 23 patients. 17 were severe disease, 7 had critical. That's right now, of the 23 patients, 100% survival, 100% as of right now, which, just this, and my understanding is it's going to be in the in a supplemental section of the Nature magazine this week. So you guys keep your eyes out on that. Now, I know there was a question about the CD4, CD8. How is it working? I don't really know. When I was looking through the preprint, they didn't really address that. My take on it is by clearing your immune system or freeing up your cytokine storm, you're redirecting your immune cells to fight the virus. The other important point about leronlimab is there's something called polarization. Your macrophages can either be pro-inflammatory or anti-inflammatory. It's M1 or M2. M1 are your pro-inflammatory, M2 is your anti-inflammatory. And this study is showing that leronlimab is able to change the phenotype of macrophages from pro-inflammatory to anti-inflammatory. And that's obviously contributing an effect on the CD4, CD8 counts.
Yeah, someone was asking about the blood type and so the blood type came about because there's a study done in China. So on Chinese COVID-19 patients, they found that the blood type of type A seemed to have less COVID compared to all the others. So even the authors of this study in China, they themselves noted that you have to interpret this with caution because there might be an association with that, but it's definitely not a proven correlation, or at least based on those numbers, because it wasn't that many patients in the study. So it could be just a coincidence. There might be an association. We don't know yet. So definitely too early to say one way or another. And then someone else was asking about, can you get 2 viruses at the same time? Yeah, actually, so not all hospitals, but lots of hospitals, what we do is we do what's called a respiratory viral panel. And what that does is it's off PCR-wise for a bunch of different viruses that could be causing infection. And there's been, times where we see one patient have more than one virus, and such as, parainfluenza virus. There's 4 coronaviruses besides this COVID-19. So I've seen someone with a regular coronavirus in addition to parainfluenza. There's also a human metapneumovirus. There's rhinoviruses. There's adenovirus. So there's all these sorts of respiratory viruses that can cause a respiratory infection, and it is possible to get more than one. And it is possible that someone could get COVID and influenza at the same time, although I have not seen any. I have not heard of any of my colleagues having that happen, but there's no reason why it can't happen to them. That would be very unfortunate to get both. But if it does happen, I don't think it's very common. I think it's pretty rare that it does happen, but I will say it is possible. And someone else was asking about, can you give angiotensin 1.7? Yeah, if you've seen my videos, you know that angiotensin 1.7, 1.9, and the whole relation to ACE inhibitors and angiotensin receptor blockers and this ACE2 enzyme, which is the same enzyme that allows viral entry. There's a lot of correlation there, and when the ACE2 receptor is downregulated, as what happens with the virus in the alveolar cells, then there's less ACE2 enzyme activity on the cell, which actually affects the balance of the pathway of all those chemical reactions going on with the ACE2 and ACE inhibitor pathway. So what ends up happening is you have a shift towards more angiotensin 1.7, less angiotensin 1.7, angiotensin 1.9, and that causes less stimulation of the MAS-R pathway, the MAS receptor pathway. And when that happens, you actually end up with more inflammation, more vasospasm, meaning constriction of the pulmonary blood vessels that are there, and more prone to developing clots in the lungs. So the question is, well, can you just give angiotensin 1.7? So I don't think that's an option, at least as of right now. I haven't read any studies on it. What they are looking at, besides randomized controlled trials with ARBs such as losartan, also looking at ACE inhibitors in randomized controlled trials, they're looking at this thing called recombinant human ACE2 protein. So that's in the IV form where you inject it into the blood, and this ACE2 is really what they're giving here, this ACE2 enzyme, and the hope that with this enzyme being given, it's going to cause less inflammation by means of more angiotensin 1.7, angiotensin 1.9. So no angiotensin 1.7 being directly, but they are giving this recombinant ACE2 enzyme through IV. So we'll see what that randomized controlled trial shows, and hopefully we get some good results really soon.
Mike, I have a question for you actually on this. I know just talking to you offline, you're pretty big on the recombinant, the ACE inhibitors. What are your feelings on what do you feel very strongly about that?
Well, when you look at the pathway of all the interactions between the ACE2 enzyme that's on the surface on the surface of the cell, the alveolar type 2 cell, the ACE2 that's there, that actually gets downregulated by the virus. And when there's less ACE2, that of course is going to alter the pathway and the balance of all the chemical reactions that it impacts, at least in the lungs, because there it might not have as much systemic effect, but it does have at least a local effect based on previous studies when you alter this enzyme that's there. So when you look at the pathway, there's the angiotensin converting enzyme, that's the first one, and then there's the other angiotensin converting enzyme, number 2, that's the one that's on the virus, that allows for the virus to gain entry. Angiotensin converting enzyme, as the name implies, it converts angiotensinogen to angiotensin 1. And then there's going to be conversion to angiotensin 2. Excuse me, I got that wrong. Angiotensinogen is converted to angiotensin 1 by renin, and then angiotensin 1 is converted to angiotensin 2 by the ACE enzyme, angiotensin converting enzyme. This leads to more angiotensin 2 in the lungs, and when that happens, that binds to the receptors there and causes vasoconstriction. And if it's too much out of balance with the angiotensin 1.7 and 1.9, it's going to lead to not only vasoconstriction but more inflammation. More inflammation, also more tendency to form clots there. So if you have the scale, where's my hand? If you have the scales, it's one way or the other. If you have it more this way, it's going to cause more clotting, more inflammation, and more clot formation. But if you have it this way, it'll cause less of that. So what you want to do, normally, in a normal person, me and you right now, it's in balance. Okay, mm-hmm. But with this COVID infection, it's throwing it out of balance.
Mm-hmm.
And so
that finish.
Yeah, so that's the theory behind giving this recombinant ACE2 drug, is to essentially restore the balance. And the hope is with losartan or other ARBs, the hope is they'll also restore the balance. And the same thing with ACE inhibitors. Right. Although I think the ones that are going to do the best job of restoring that balance will be most likely ARBs and the recombinant ACE2, based on what you see in that pathway and how those enzymes work. But only time will tell based on the randomized controlled trials. I will say this, there have been recent studies, observational studies, where they looked at who was taking the ACEs in the ARBs. So people who take them for high blood pressure, for congestive heart failure, for diabetic nephropathy, for coronary artery disease. For these people who are taking either ACE inhibitors such as lisinopril or ARBs such as losartan, the ones who are taking these medications, they at least did not do any worse. Because that was another concern, is, well, maybe these medications are upregulating the ACE2 receptor, and therefore the virus can gain more entry into these cells. Well, what they showed in these studies, or what they observed, was that they didn't have any worse outcomes. And it's yet to be determined if they actually have benefit, because it's so hard to do. You can't really do an observational study. You need randomized controlled trials, which they're currently in as we speak. And based on these randomized controlled trials, then you can make a conclusion as to whether or not they're working to either prevent or reduce the severity of COVID-19.
Right. Mike, I'm just getting a ton more questions about leronlimab. That I felt like I knew this was going to be sort of the questions I'm going to be getting a lot. I'm just going to address these. So if you guys just have leronlimab questions, just give them to me right now, so we don't have to keep on coming back to them. Okay, leronlimab prescribed on an outpatient basis. No, it's a sub-Q injection, 700 milligrams right to your abdomen. It's a 2-week. You take one every 7 days. The trial, there's I think one patient that didn't get it in the study that's coming out, but everyone else has got two doses of leronlimab. Like I said, you guys are going to be blown away when you see these results. The other question someone asked about the politics of using leronlimab as a monotherapy. So Dr. Patterson talked about this. They are aware. Could they use it with remdesivir? Because leronlimab is showing some antiviral. It's reducing the viral load from their study from Montefiore. So it could be just a monotherapy. We don't really know right now if it's going to be a combination with a antiviral like remdesivir or something else. Okay, now the next question I had is, why hasn't there been more coverage of leronlimab? The FDA is really, they kind of are putting a lot of roadblocks and putting a lot of things with remdesivir, which, I've talked a lot about remdesivir in my other videos. If you looked at the study, Dr. Mike and I, we were talking about this offline. After day 5, there is a precipitous drop in the effectiveness. It is just as effective as placebo. So the thing with remdesivir is you need to give the medication early, within the first 5 days. But here is sort of the dilemma. When I'm looking at data from 3 different hospitals around the United States, from the onset of symptoms till the time someone gets into the ICU setting, it's usually about a week. I don't know, Mike, what you're seeing in your ICU, but I'm getting some raw data from around the country, and it's usually like the 5 to 7 day period, people are at home. They've got some, like a mild cold or some minor symptoms. By the time they're getting to the hospital with severe symptoms and getting intubated, it's probably like a day or two, and it might be too late for remdesivir. I don't know. I'm just looking at the study that came out and kind of correlating with some of the raw data that I'm getting from a couple of hospitals.
Well, it's so hard because even with these studies, you don't know who is getting the virus at what point in time, and you can't prove it one way or another. For example, we know that about the 14-day quarantine time is based on the time that it takes from the longest duration of when you first get the virus to the time you manifest the disease with symptoms. 30% of people don't get symptoms. If you do get symptoms, how do we know what day it is? How do we know it's day 1 versus day 7 versus day 14? There's no way to know. It's impossible. And these studies don't know either. There's no way to determine that. So at what point do they actually get the virus? And then you say, well, we're going to count day 1 as the onset of symptoms, and that's fine, but you don't know what's really going on inside those lungs. You don't know how long that thing's been brewing there. Something that we do know is that some people don't have bad disease. Most people, 80% of people, don't have bad disease. Then there's other certain percentage, maybe 15%, that get COVID pneumonia. Even sometimes lots of patients with COVID pneumonia don't actually have symptoms, at least in the beginning. There's been times where COVID patients have pneumonia based on they see that on an X-ray or CT scan, and they don't have symptoms. And then there's been other times where they get severe disease, where you have ARDS to the point of requiring a ventilator. That's about 2%. So at what, the other thing too is there's been times where people who have the COVID pneumonia and they require supplemental oxygen by a nasal cannula or high flow nasal cannula or even a CPAP mask. And then all of a sudden they just, as at the blink of an eye, within, maybe a couple hours, they all of a sudden have further deterioration in their oxygen, and we're rushing them to the intensive care unit for a breathing tube. So things can look very stable for a while and then all of a sudden get really bad really fast. And there seems to be these different subsets of patients. You have the ones who don't get any symptoms at all. You get the ones who get mild symptoms that are cold-like symptoms. You have people who do get short of breath with the COVID pneumonia and do okay with supplemental oxygen, and then they go home and they get better. Then you have that patients who have the pneumonia and then they're on the supplemental oxygen, and then they all of a sudden get really bad really fast and they require a breathing tube. And of course, we have subsets of patients who end up dying. And then you have a whole other category of people who have strange symptoms, whether there's been people who've had meningitis, inflammation of the meninges. There's been people who've had seizures. There's been people who've had Guillain-Barré syndrome. There's been someone who's had just GI, people with just GI symptoms, nausea, vomiting, belly pain, abnormal skin findings. This gets to the COVID toes. People who are presenting with just having a blood clot in their lungs, pulmonary emboli. Now there's Kawasaki disease as a potential, someone who's asking about that. There's been a 6-year-old who got Kawasaki disease and tested positive for the virus. So there's all sorts of these strange presentations, which, by the way, this is the topic of my next video, is all these strange presentations and all the different autopsy findings that we're seeing. But anyway, the point being is that this disease is like no other disease in the history of mankind, where it can present in so many different ways, and it not only causes inflammation, but also causes clots, and some people are fine while some people die. It's such a strange disease that we have so much to learn about it, and it's going to take a long time to figure this out because there's just so much to uncover here. So,
Mike, no, finish
no,
your
no,
point.
I'm
I
done.
was
Go
going to
ahead.
add
Go
something.
ahead.
If you guys want to see the article or the case study that Dr. Hansen referred, if you go to my community page, Mike, you can put it on your community page too. You can read the case report. My sister is a pediatrician, so she has all the data from the American Association of Pediatrics. She sent it to me this morning, looking at it's a case study, I think somewhere out in California at Stanford University, a 6-month-old. They suspected Kawasaki, which is a vasculitis and inflammation of the sort of the endothelial wall. One of the telltale signs is a coronary involvement with Kawasaki. This particular patient did not have it. So there is a little bit of confusion. Is it really Kawasaki? The 6-month-old tested for COVID-19. So you can guys go just see the case study on my community wall. I'm going to just sort of follow up on what Dr. Mike said. Great point about the presentation. And it's going to be really exciting to see your video, because I also got this. I've been getting a lot of questions now on my end, Mike, about glycans and carbohydrates, and that really ties into what you said about this being just it's not like any other virus or condition we've seen, really in our medical textbooks. So it really presents us a big challenge. I'm just going to quickly touch upon this, and we'll get more questions, and you guys can message me offline. I believe that coronavirus is a carbohydrate recognition virus. This is documented. This is in reports that influenza, rotavirus, I think even herpes are carbohydrate recognition viruses. Now, the spike protein Dr. Mike has been talking a lot about is covered by a sugar called a glycan, and this is where the research is going, is that sugar molecule. So I theorize that the sugar is playing a role. Follow the sugar, and it's having some role with a molecule called galectin. I think it has a role with red blood cells, and they're all firing up the cytokines. You guys can see the video. I'm not going to sit there and talk about the entire pathogenesis right now. A ton more questions to get to, but I just wanted to say that Dr. Mike is, really, it's interesting. He brought up the point about how there's so many different pathways and presentations, and trying to find an explanation. It's who is right and who is wrong. So, anyways, you guys can just message me offline. I'm happy to have this conversation. So let's move on.
Yeah, so someone was asking about colchicine. So colchicine is interesting. Colchicine treats gout. It also treats pericarditis. The way that it works is when someone has a gout flare, the uremic crystals that form there, the macrophages, which are part of our immune system, the macrophages travel to those crystals and then they eat those crystals. And that triggers this whole inflammatory response. And what colchicine does, it actually inhibits that process of those macrophages. The way that it works for pericarditis, which is inflammation of the pericardium is the sac that goes around our heart. So our heart sits in a sac. And sometimes that sac gets inflamed and it can fill up with fluid on the inside and then push on the heart. So pericarditis is sometimes not a big deal, but sometimes it is a big deal. But anyway, pericarditis can cause pain, chest pain. It can be difficult to breathe, and it can cause other complications. Sometimes when we treat pericarditis, we treat it with colchicine. The way that it works for that exactly is not known. In terms of colchicine for COVID, I haven't seen any studies on that. I don't know why it would specifically work for COVID, maybe potentially interfering with the macrophage's ability, and maybe that will impair the cytokine storm, but I can't say one way or another because we just don't have any studies on that. In terms of, do I think it's gonna, if someone gets colchicine, do I think it's gonna work or prevent COVID? Probably not, because I think COVID is just way more complicated than that. But again, we'll see. I'm not aware of it being in any clinical trials, but maybe it is. There's over 300 studies going on with different drugs, and it's hard to keep track of them all. But I haven't heard of any colchicine trials as of yet.
I'm going to, I got a lot of questions a little bit earlier, and guys, you have some questions. I'm going to, if I don't get to it, I'll try to answer them offline. I want to shift gears a little bit, Micah. The vaccines are sort of been in the news a lot. So we got a couple of questions, I know, on Dr. Mike's feed and on mine too. So there's a couple of different vaccines. I went in depth I did a vaccine video, kind of talking a little bit about all these vaccines in depth and what they mean and how they're being manufactured and developed. Sort of the one thing that's big in the news is a company called Moderna, and they made this. It's an mRNA 1273 vaccine. How it basically works is they've taken the code for the spike protein and they've made an mRNA. It's a genetic code. Just think about it. The virus is a code, and in the code it tells what and how to make it. So what they've done is they've identified the sequence for the spike protein, made the RNA code. The principle is they inject it into you, and your own cells will make a copy of spike protein. And just like your body would if the virus presented itself, you would have your adaptive immune system would take place and make antibodies to it. That's the principle behind it. The other big virus that everyone's talking about is AstraZeneca and University of Oxford. They have made what's called the ChAdOx CoV or nCoV 19 vaccine. I can't remember what it stands for. But what it is they've taken adenovirus, a chimpanzee adenovirus. Moderna, Moderna. That's the name of the company, Mordena, and the mRNA 1273. The other one, like I said, is made by University of Oxford and AstraZeneca. They just signed a partnership a couple of days ago. They are using a weakened adenovirus from a chimpanzee, and they have put the code for the spike protein on the adenovirus, and it's called a vector vaccine. And when you inject that into the human, the idea again is that you'll replicate the spike protein, and then you build an adaptive immune response. Now, the other major drug company is Inovio. There's been a little bit of controversy with this company. I've been sort of following them in the last couple of months. They are having a DNA vaccine, just like Moderna and the mRNA. What was really a little concerning for me was someone in the company, maybe the CEO or someone involved with the company, was talking about how once they found the genomic sequence for COVID-19, they used a computer algorithm and built a sequence for the spike protein using DNA. So it just seemed a little. They said in 3 hours they were able to build. I don't know if you saw that, Mike, but they said in 3 hours they were able to build the spike protein. Just seems a little weird for me. But what's the most promising right now? It's probably the mRNA, the Oxford study, or the Oxford, the adenovirus vector that they're using also seems pretty promising. The one thing to remember is they're probably going to target high populations like healthcare workers when there is a vaccine that's available. And in terms of a mass campaign, it's probably going to be sometime next year. I mean, that's just the realistic thing to keep in mind. The thing about why they're able to quickly make these vaccines is by using some of the new modern, like the RNA and the DNAs and these other vectors that they're using. They don't have to grow it in a lab like the attenuated or the weakened virus that we used before, so that they are able to quickly produce it. The problem, what we don't know, is are these vaccines going to be effective? And even if they do confirm immunity, how long do they confer immunity, and how much do they confer immunity against the virus? And that's just a great unknown that we're facing right now.
Yeah, I mean, it is plausible that they came up with the vaccine so quickly because the virus is so similar to the SARS-1 virus. And so they've been working on that virus and decoding that for a long time. So they kind of had a head start in terms of coming up with a vaccine for this one. A lot of people are asking about hydroxychloroquine. The trials just aren't showing much benefit. I mean, if at all. And they give, one of these trials, they had the dose was 3 times the standard dose, and at that dose it was causing more side effects, more arrhythmias. So I know there's still trials going on, but so far it's not looking promising at all. Dr. Yo?
I agree. I made a video about how I was not sure how effective hydroxychloroquine was, and I thought that probably half the people that were watching my video wanted to rip my head open because they disagreed with it. And my point is, I don't tell people what they want to hear. I tell them what they need to hear, and that's always based on clinical studies and kind of what other physicians are telling me and what I'm seeing clinically too. My understanding from my clinical experience and also talking with other critical care doctors around the country is around the middle of March, most of them stopped giving hydroxychloroquine with azithromycin and even zinc in some instances. Didn't find any benefit. They started giving remdesivir and tocilizumab. And I can tell you this right now, most of them are saying they were not effective, at least in a critical care perspective. And going back to Leronlimab, looking at the data, a lot of them were treated with hydroxychloroquine and remdesivir and tocilizumab or just tocilizumab. They did not show any benefit, but the moment they got Leronlimab, within a couple of days, a lot of them got extubated. A lot of them got home in the next couple of days. It's mind-boggling when you guys see this data that's coming out.
Yeah, someone was asking about, can you get reinfected? With the previous coronaviruses, these viruses, we don't really do a good job with our antibodies for whatever reason against these viruses. These viruses just have a way of coming back. You might have temporary immunity to a coronavirus, including this one. But either way, it has been proven one way or another. I would believe, and again, we don't know this for sure, I believe that when you get the infection, you developed IgG and IgM antibodies. The IgM antibodies are, this we know for sure. You develop the antibodies, IgM first and then IgG. IgM takes about 7 days to develop, IgG a little longer, 2 to 3 weeks. Once you have those antibodies, you most likely cannot get reinfected for at least a certain amount of time. The question is, how long is that good for? Is it forever? Probably not. Is it for a year? Who knows? Is it for a few weeks to a few months? Maybe. So that's the big question that scientists are trying to look at is when someone has these antibodies, how long are they protected for? And at this point, we just don't know how long. And yeah, and someone else was asking about rheumatoid arthritis. So people who are on biologic agents for such as rheumatoid arthritis, sometimes for lupus, sometimes for Crohn's disease, sometimes for psoriatic arthritis, these biological agents, there's tons of them that are out there. And they each work in their own way relative to the immune system. So some might inhibit TNF, which is part of the immune system. Some might be an antibody to a specific interleukin. There's IL-1, IL-2, IL-6, IL-8, IL-10. There's so many interleukins out there. So there's a bunch of these different biological agents that somehow impact or inhibit parts of the immune system. And so there's a possibility that some of these, such as tocilizumab, which inhibits IL-6, there's a possibility that people who take that drug might do better compared to people who don't take that drug when it comes to either getting COVID or having severe disease with COVID. So, the biologic agents that someone is on, it may or may not be helpful or harmful to them. We just don't know at this point. And that's why these studies that are still ongoing, we don't know when they're going to be ready. Some of them are coming out, just like remdesivir. Hopefully get some more good results soon, such as with tocilizumab and some of the other ones. Yes, Rachel Kingsley said biologics are expensive though. Yes, they are. And some are more prone to giving more side effects than others. Some are more prone to having people, immunocompromising their immune system. So, it might help with COVID if one does show to help, while at the same time it might, put them at increased risk for different infections such as hepatitis C, hepatitis B, tuberculosis, and other infections. So, lots to be learned about this. Is metabolic syndrome contributing? That's a good question. The thing with a lot of these patients with COVID, especially the ones who are getting clots, there seems to be this endothelial involvement. Now, what I'm talking about endothelium, so our blood vessels, the very inner lining of our blood vessels, including the capillaries in our lungs, that's called the endothelium. These are very, very thin cells. And when someone has COVID infection, especially when someone has ARDS, we know that two things happen there. There's inflammation there, where these capillaries in the lungs, they not only get bigger, they get swollen essentially, and there's fluid leakage going in and out of them, but also the cells that are there have ACE2 receptors. So the virus not only infects the alveolar cells, the type 2 alveoli, but also right next door, its next door neighbor, it goes and grabs onto the ACE2 receptor of the endothelial cells. And so that leads to inflammation, that leads to fluid moving in and out of there. So fluids going into the alveoli, causing pulmonary edema. But what else is going on there is the propensity to develop clots, so thrombin generation, so platelet activating factor. So that's this initiation of clotting. That's why we see lots of thrombi, lots of fibrin. Okay, that's why you have high D-dimer levels in severe disease, because that's a part of the process of clot formation. And The endothelium is shown to be at a predisposition. It's more sensitive in people who have atherosclerosis. So people who are tend to have endothelial damage or more prone to endothelial damage are the same people who fit that profile for metabolic syndrome, who fit that profile for coronary artery disease. And what does that profile mean? High blood pressure, diabetes, being male, being a smoker. So these things, and I'll talk about this in my next video, but these things make the endothelium more prone to destruction. So that's probably not a coincidence why people who have worse disease are the ones who have high blood pressure, are the ones who have diabetes, who are smokers, and who are older. So all these factors make sense as to, okay, their endothelium is more prone to destruction, and they have these same risk factors that we already know about. So it's a very interesting correlation there, which I'll get to in my next video. But yes, the endothelium, no doubt about it, is playing a big role in patients with severe disease. It's going to play a big role in inflammation and clot formation and pulmonary edema. And you have to remember that the ACE2 receptor lies in the endothelium. And the endothelium lines the blood vessels, so it's in the kidneys, the heart, not just the lungs.
Mike, I just got a question directed to you on my end from Kenny. Goes, ACE2 inhibitors increased with blood pressure meds. Can you?
Yeah, so
I
think what the question is getting at is this possibility of having ACE2 receptor upregulation, not downregulation. So when they looked at people who actually they didn't look at this in people, they're looking at this in rats. So they gave rats 28 days worth of losartan, and what they found was these rats had more ACE2 receptors in their coronary arteries, in their heart muscle. So this was, again, giving losartan for 28 days in rats and looking at the heart. So based on that, there's speculation that, well, if people are on losartan or other ARBs, does that mean there'll be more ACE2 receptors in the lungs? And then these people will have more ACE2 receptors, therefore there will be more chances for the virus to invade if there's more ACE2 receptors? That's a theory. And that's why there's this big debate about whether or not ACE inhibitors and ARBs are actually beneficial or harmful when it comes to getting COVID and severity of COVID. But like I mentioned earlier in this video, the ACEs and the ARBs actually did not have any worse outcomes based on the studies that we have so far. But again, these are all observational studies. And I think with these randomized controlled trials that we're seeing that are taking place right now with the ARBs, with the ACE inhibitors, I think there will be some benefit to people who are on them. I really do.
Mike, there was an interesting thing, and I got a couple of questions on Instagram about this. And this is probably going to tie into that, so I'm just going to make a quick comment on it and answer some of the questions. I got a couple of questions on galactans. And this is investigational. This is something that my research is looking into. I talked to a couple of university hospitals around the country. One of the things, as Dr. Mike said, is finding what I believe is to identify by risk which patients are going to be more likely to have going to have severe symptoms or moderate symptoms, or just sort of be able to get over the disease. Think about it: 80 to 85% of people are going to do well with COVID-19. The problem is the other 15 to 20%, and even of that, a much more smaller group of people are going to have, be intubated and have really severe sequelae from the infection. So the real key is to develop some sort of scoring scale that, in my opinion, that's going to help physicians be able to stratify by risk. And one of the things I'm really looking at and speaking with a couple of researchers in developing is serum markers. And one of them I'm really strongly looking at is galectin and galectin-3, which correlates. If you guys look at a lot of studies, patients that have, I know we were just talking about metabolic syndrome, patients with diabetes, hypertension, atherosclerosis tend to have higher serum galectin-3 levels. And could there be some correlation between galectin and the COVID-19 glycans having some interaction. We don't know. That's where my research and my interest lies. So I just wanted to kind of throw that out there. Is we're trying to develop sort of a risk stratification. Because here's the thing: when I'm looking at raw data right now, it looks like the medical community had no idea what they were doing. Some people were getting hydroxychloroquine on day 1. Some were getting it on day 10. Some were getting remdesivir on day 1 and tocilizumab day 7. Some were getting doxycycline. I can't even understand why these people on admission were getting doxycycline. It's mind-boggling. Some were getting azithromycin, but not hydroxychloroquine. There were no protocols, and this is something I've been mentioning in my videos. We didn't have anything to go by, and it's like, let's throw something against the wall and hope it sticks. Well, nothing's really stuck. So I just kind of wanted to make that point. I got a bunch of questions about galectin, so you guys can go read up on it. Send me a message. We can talk offline because I know we got a bunch more questions that we need to tackle in the next couple minutes.
Yeah. So someone's asking about vitamin D. Yeah, I mean, vitamin D. Again, we don't have data on vitamin D when it comes to COVID. There was a big meta-analysis done a few years ago that looked at vitamin D, people who were deficient in vitamin D and people who weren't deficient, and looking at the numbers of how many upper respiratory infections, viral infections they're getting when it comes to influenza and other respiratory viruses. And so based on that meta-analysis, meaning they looked at a bunch of different other trials, they determined or came to the conclusion that with low vitamin D levels, or for those who were deficient, they were more likely to get viral infections of the lungs. So the ones who had the benefit were the ones who were taking 1,000 to 2,000, basically low dose vitamin D on a consistent basis, as opposed to the ones who would less frequently get big doses of vitamin D. And so based on that meta-analysis, they said, well, it looks like you're more prone to getting viral infections of the lungs if you're vitamin D deficient. So does that necessarily apply to this COVID virus? Probably. That's my conclusion. But again, we don't know. There's no studies to say yes or no on that. Me, what I do is I do take vitamin D. I take 1,000 or 2,000 every day because that's certainly not going to hurt. And so that's, what I do for myself. I'd recommend that for anyone really, especially if they think that they're not getting enough vitamin D. So if you're not out in the sun in the Caribbean every day or something like that, and you expect that you're not getting enough vitamin D from the sun, then I think it's reasonable for people to take vitamin D every day.
I want to bring something pretty interesting to everyone's attention. I actually just stumbled upon this drug about 2 days ago. I'm not sure if you heard this, Mike. It's out of England, and it's a company called Pnumagen, Pnumagen. They came up with it's almost like an inhaler. It's called Pneumafil, Neumifil. I'm going to try to dig in a little bit more, try to get you guys some more information. But I stumbled upon this about two nights ago, and what it is, it actually blocks the carbohydrate from spike protein on that's covering the spike protein. So I wanted I'm going to post a link to this study on my community wall. Dr. Mike and I'm going to pick his brains on it too, since he's the lung specialist. But the study is there's a lot of report of positive data coming from this new drug. I'll post that. Yes, it's spelled Pnumagen. I'll post a link to the study. So one of the things Dr. Mike and I are trying to do is we're just trying to give you the updated information, what's out there. We are like everyone else, just trying to sort through all of this. So it looks pretty promising. I just found it out 2 days ago, so I just wanted to throw that out there.
Yep. All right. So, any other final thoughts, Dr. Yo?
No, I just want to thank everyone who to everyone who sent wonderful messages of encouragement and checking in on me and my colleague. Dr. Mahoney, he was one of my ICU attending. I trained at SUNY Downstate in Brooklyn, New York. He unfortunately passed away of COVID-19 a couple of days ago. I have another colleague of mine down in Florida who is he's fighting. I just talked to him on FaceTime, so I want to thank everyone in the community that has reached out to me. It really means a lot to me that that you guys have reached out and checking up on me. This virus gotten to be pretty personal. I get a little ticked off when people think that this is not a virus or this is something else, but it's real. It's affected me. It's personal. It's killing my friend. I'm just trying to figure out an answer and a solution and help the really, really smart people out there with their research. And I know Dr. Mike, I love talking with him. He's probably one of the smartest people I've ever met. He's my med school roommate. We met 17 years ago, and it's crazy that we're still friends and we're doing this together. So it's great having him as a resource. And that's all I have to say. The one other thing I will say is, the last thing I got to say is, I practice medicine is proactive medicine. One of my other attendings that I trained with at Downstate, Dr. Demitis, who passed away in 2016, one of the greatest clinicians I'd ever met. The first thing he told me as an intern is meet the virus or the disease before it gets there. So we have to be proactive as a medical community instead of being reactive and chasing after viruses and diseases. So we got some really great minds on this, like Dr. Mike and a couple of my other colleagues. So guys, I know it seems like it's the end of the world and the media makes it seem really scary, but we're going to get down to the bottom of this, and we're going to solve this problem, and we're all going to come together and fight this really terrible virus together. And thank you all, everyone, for the wonderful messages and encouragement.
Yes, hope your friend pulls through, and thank you for all your kind words. I also want to say, someone was asking to touch up on what you're saying, in terms of preventing and staying healthy. So besides all the things that we already know about, like the hand washing and the social distancing and all that stuff, the other thing too is to get good sleep and to try to eat healthy if you can. I know it's hard going to the grocery store, and I know it's hard because lots of foods are unavailable, and washing the vegetables and all that. And I know it's hard to actually eat healthy in general. Also, financially, a lot of people are struggling right now. So it's easier said than done, but try to eat healthy, or at least on the healthier side. Try to get good sleep. It's not, like I mentioned earlier, it's not going to hurt to take vitamin D, vitamin C for at least a little while, as long as you don't take huge doses, it isn't going to hurt either. Might not help, but it's not going to hurt. Unless you have kidney stones, then it might hurt that. But anyway, getting good sleep, reducing your stress levels, which, hey, look, we're all stressed out right now, right? These are tough times. But things that you can do to reduce stress besides exercise, which you should be doing anyway, you're going to want to reduce that stress. So eliminate things that are causing stress in your life. And maybe do some relaxation techniques, yoga or mindfulness, whatever it is that you do. You can go running outside if you like to run. You can run without, coming into close contact with other people for the most part, depending on where you live. So exercise, eating healthy, maybe some vitamins, getting good sleep, practicing all the things that we already talked about with the hand washing and not touching your face and covering, inner elbow, of course, the masks as well, depending on where you are. So all these things, just, I know it kind of becomes tiresome. It's the same thing every day over and over. But listen, we'll get through this. In terms of vaccinations and medicines, there's things that are looking promising, things that are coming down the pipe. Who knows what's going to happen? Who knows how long it's going to be for? But as long as we keep staying strong and doing what we're doing, and keep staying informed as well with good sources, based on science, based on expertise. So that's where we're at, and I do want to say thanks for all your questions, all great questions, and thanks for your comments. Thanks for chiming in, and glad to do this. I'm glad to get online with other people and do something together. You know, I'm just here. And, you know, Dr. Yo is there, and it's nice doing things with other people without necessarily, you know, being in physical close quarters. So anyway, thanks again for everything, and who wants to do it again next Sunday?
Me, I think we also we're thinking about doing this even once we knock out this COVID-19. We're thinking about just doing this every week, and we have a lot of other physician friends and experts that we'll just do topics and fitness, health, because we realize there's just a lot of some questions that are things out there on the internet and social media that are a little questionable. Let's put it that way. So we like to just sort of be in the forefront and so at least give you research-based um, information. Also, you guys should ask Dr. Mike about his drumming history. He's talking about rest, relaxation, and eating well. He's also got to say playing music. He's a pretty incredible drummer. He was the drummer in my band when we were in New York. So you guys should send him messages about that and ask him about his music career. He's talented.
I'm not that good of a drummer, but anyway, my Instagram is Dr. Hansen, so DOCTOR.HANSEN. If you want to ask me questions on there, and I'll either answer them there or incorporate them into the Q&A next Sunday. And I know people want to go and watch the Michael Jordan documentary, so we don't want to keep you any longer.
Oh yeah, let's do that. Yeah, and I'm at ECA Wellness on Instagram, Dr. Yo on YouTube, Dr. Mike is Dr. Mike on Instagram, right? And Dr. Mike Hansen on YouTube.
Oh,
If you haven't
it's
added him already,
Dr. Hansen on Instagram, and then on YouTube it's Dr. Mike Hansen spelled out. So.
sounds good. All right,
All
guys,
right.
we'll see you next week.
Thanks a lot,
Thank you very
everyone.
much.
Take care.
Thank you. Bye bye.